Welcome back to Isaac's Dentistry. Today we're going to cover something that often overlooked or not taken as seriously as it probably should be, but it's extremely important both to you as a patient when you go to the dentist and for us here in the dental office when we go to treat you and determine which course of action is best. I'm holding in my hand right now, it's the paperwork we have everybody fill out, and if you've been a patient of ours for a while, you have one on file. But the part I want to focus on today is your medical history and why that's so important when you come even to the dentist, those medical problems that may not even be related to your mouth and why they're so important to us here and to you as a patient and the different complications and the things those can cause. Especially I wanted to bring it up because if you've been a patient of your dentist or hopefully here at our office for a long period of time and that medical history has changed a little bit, it's so important to let us know so the doctor can be aware of what those changes are because they can impact a successful outcome and treatment of what's going on with you here in the dental office. So Doc, right off the bat, just generally, what would you consider the top 4 or 5 medical history things that we really need to be aware of?
Okay. Well, yeah, Scott, you touched that, and of course, let me just kind of go back. The first page that we have is all dental related, and I would say probably there's only about 2 or 3 of them that we even look at on that, because as soon as we take an x-ray, take a Panorex, or do a visual oral exam, we can pretty much tell what's going on with that. So we don't need a whole lot of that, but we do make sure that you don't have any kind of concern. So
right.
Really that's the concern page. Now this is what our concern is how we first do no harm. That's right. In the Hippocratic Oath, primum non nocere, which is Latin for first do no harm. And there are 5 every patient before I take a tooth out, I always ask them five questions. And Scott knows the 5 questions because he's probably heard me say it maybe 500 times. In no certain order, we just make sure we got them. I always say, how is your heart? Do you have any heart problems? And they might start telling me some kind of history. If they don't say anything, then I say, have you ever had any heart surgeries? That's really what we want to know. Have you had any heart surgeries? The second one, have you had any joint replacements? Knees or elbows? We always ask that. And here in just a second, we'll tell you why the big 5. And then we say, are you a diabetic? Have you type 1 or type 2? It matters slightly, but we want to know about the healing. That's what we're doing there. On women, osteoporosis. It's generally a female problem, but are you being treated with bisphosphonates, which is a very strong bone growth inhibitor, and we want to make sure you're not taking that. Actually, it's a bone destroyer inhibitor, but we're worried about the bone growth.
Right.
Okay. And then lastly is blood thinners. Any warfarin, Coumadin, or Plavix, those type of drugs. And there's a myriad of new ones out that we used to use a PDR. We just use the Google now and Google the name of the drug, and it comes up, and we can tell it what we should do with that. So it's a very handy tool.
Right, and you started off by saying these are the big 5 questions we ask for an extraction, but these are also very important 5 things we need to know for other procedures as well, whether we're doing maybe a crown prep or a bridge.
Sure.
There are other things.
Right. If this morning we had 2 people already this morning that need to be pre-medicated. Mm-hmm. And what's that mean? Well, we got to give them the pre-medication we're talking about is not sedation in this instance. It's pre-medication for a mitral valve prolapse. They've got what's called regurgitation in their heart valves and the mitral valve of their heart inside the heart. That whenever their heart pumps and beats, there's some blood, residual blood is there, and it never gets rid of. So we want to make sure we don't cause any vegetation from a bacterial growth, because the same bacteria that's in your mouth can affect the vegetation in your heart. A heart valve, not on the outside. This we're talking about right. In the inside of your heart. That's why we ask, have you ever had any heart surgeries? If you've had coronary disease on the outside of the heart, we need to know that too for the stents. But we're not concerned as much as we are the inside.
Right, and that pre-medication is an antibiotic to keep that growth from happening and keep any infection from spreading anywhere that we seriously don't want it to.
Yes, we use when somebody does have a prolapse or congenital heart lesions, valve problems, valve replacement, anything like that, we usually give, if they can't take penicillin, we use amoxicillin. We use 2,000 milligrams of amoxicillin, which is a mega dose. We go ahead and give them 4 of those big tablets, let them swallow it, and just really, as soon as we start, we always say it's better to get it 1 hour before, but if we get it while you're there in the office, we got you covered. When I first started doing this, and when I was in dental school, you had to give 6 before and then 3 after, 6 hours after. Now the studies have shown you don't have to do that anymore. And before I was a dentist, people would have to take it 3 days before and 2 days after. So it has changed.
So folks out there thinking, okay, well, I had a heart attack last year. They didn't do any stents, they didn't do bypass surgery, but I did have a confirmed heart attack. We need to know that.
We'd like to know it because we are going to use drugs that will potentially increase your heart rate and your blood pressure. So we use a lot of epinephrine, so that will do that.
Right.
So we want to know how healthy your heart is, how much to give you.
Right.
Okay, kind of vague. But if you've rule of thumb, if you've had a heart attack, we do know elective dental treatment for 6 months. If you've had an established heart attack, nothing for 6 months, and no extractions for 1 year if we can help it. Now we have a couple here that were kind of they've just had a recent heart attack and they're on blood thinners, so the doctors won't let them off the blood thinners, so we'll treat them with antibiotics and doing a little incise and drain. We're draining the abscesses instead of getting them out because we can't stop the bleeding.
Right, and don't think that just because you may have some of these things that you still can't be treated. There are ways we can do it. We coordinate very closely with a lot of primary care physicians, and we've reached out to cardiologists to make sure that we're working in tandem to make sure that you as the patient are staying safe and we're still able to take care of whatever problems you are having on the dental side without just putting them off or kicking the can down the road and letting them get worse.
We can always get you out of pain. There's something we can do. We can either drain the abscess, give you some Marcaine injection, which is a long-acting anesthetic, to get you out of pain until the antibiotics kick in.
Right.
Now, if it's worse, it's rare, but sometimes we'll send you to the surgeon, the oral surgeon, be sedated and do it in the hospital. The surgeons won't do that either. If they can wait that 6 months, they will do it and do it with not on Coumadin. Matter of fact, we got a patient in the chair right now that's on Coumadin. Well, actually, he went off 2 days ago, and we're taking the teeth out right now. So, so that's how common this is.
Yeah. So that's one of our big questions. Any heart surgeries or blood thinners, so 2 of them. Diabetes. So again, a lot of these are going to focus on extractions, but again, it'll affect things like crown preps and things where we're a little more invasive. Why is it so important for us to know about that diabetes aspect when it comes to healing and recovery?
Primarily because of healing, because diabetics have a prolonged healing episodic problem. Once the diabetes is well established and they're uncontrolled, we try not to do anything. On a controlled diabetic, you can go ahead and take the teeth out and do a crown prep, but if they're uncontrolled, we want to get you controlled first. Not only that, once we lay you back and we get you a little nervous and we give you some of that epinephrine and your blood starts kicking, there's a chance you could get sick, and now you're starting to burn all your sugar off and you've lost it. So now you're a medical patient instead of a dental patient. We certainly don't want that.
Right. And several years ago, the question of joint replacements was probably very rare. They weren't as common as they are now. Now seems like they're almost a dime a dozen. So when it comes to joint replacements, what is that time frame that we usually try to get past, and why is that such a concern for us?
Good question. Years ago, when they did the studies, if you had a knee replacement, let's say knee, if you had a knee replacement, you had to be on antibiotics to see the dentist forever, perpetuity. You had to do it just to treat it so it would not reinfect. Now the studies have shown that we're probably going to go 2 years on that, and I've heard studies saying now they're not even going to start doing it anymore. But for right now, we're doing it 2 years.
Right.
Really, I do it. We keep doing it until we hear from the MD. Once the physician clears the patient, then we're fine with it. But generally speaking, we'll 2 years on that now.
Right.
So, and that happens daily that we have somebody that.
Right, and kind of like with the cardiac issue, it's an infection issue. The body's still adapting to a foreign object in the body, in that replacement.
It's scar tissue, and it's a blood flow to the scar tissue because it's going to be. You're going to have a little bit more blood flow to it, so we're really loading that bacteria. If we cause a bacterium in your mouth, it's going to go all the way through your body, and it's going to get hung up in the scar tissue down on your knee. So that's what.
All right. So we've got blood thinners covered. We've got cardiac issues or surgeries, any heart surgeries, joint replacements, and diabetes we've covered. Okay. So osteoporosis, and again,
that's a big,
mostly female, and this is a big one too. And I know it's. We keep going back to extractions because that's one of the most invasive things we do. But for anybody out there thinking also for implants, this is where this is really going to come into play, isn't it?
Yeah, the drug Boniva was one of the first ones that came out when Sally Field was doing the commercials, and everybody wanted to figure out what she was talking about. Well, that was Boniva. That was for osteoporosis, and nobody knew it at the time. The drug is called it's a bisphosphonate, and what it does, it inhibits the osteoclasts, which are cells that eat the bones away. Your body no longer produces those, and you're saying, well, that's a good thing. Well, it's a beautiful thing, except when you have trauma to your bone, which is getting a tooth out, before the osteoblast can work, then the osteoclast has to come in and make it smooth. And if you don't have those, then the bone producing cells don't work. So they have to work in tandem. So the doctors are inhibiting the one bone, the bone eaters, and not the bone builders.
Right, because that healing process is a removal of the cells removing the scarred bone in order to give it a fresh surface for the other cells to build the new bone. And if you take half that equation away, it can really cause trouble.
Yeah, it doesn't work. I've never seen it. This came out in '93 when they first started doing the studies, but for a while you couldn't take a dental course without somebody talking about, hey, the bisphosphonates. Now we getting that under control, and a lot of doctors are pulling back a little bit on that. Another thing, if you've ever taken one, they're saying it may stay in your system forever. So we always ask that question: have you ever been treated with it?
Right.
And there's so many different drug names now. Reclassed is one too. That's one you take once a year. And from a dental standpoint, if you're going to have teeth taken out, it's better for you're on reclassed because we can time it a little bit better.
Right.
The Boniva, you cannot time that because you take it every month.
Right.
So it's always in your system.
All right. Well, and those are the big five. And again, we go from that extraction, most invasive way we can go all the way through, but they do affect everything.
For cleanings too, because if you haven't had your teeth cleaned in a while, when the hygienist gets in and cleans your teeth, there's going to be a lot of bleeding. That's just kind of goes along with it.
And that's really important because a lot of people I know show up and they're just like, well, I'm just getting my teeth cleaned, and they use that word just.
Yeah.
But a teeth cleaning is and can be an invasive procedure depending on how long it's been since your last cleaning. So even for the hygienist, it's really important to keep everybody updated on that health history.
But even a filling, you need to have it done because we go around the gum line. The only thing we don't have to be pre-medicated for with that is an injection. So we remember our promise: we can always get you out of pain. So we can give it. If you forgot to take your medicine, or you just got out of the hospital and you got a blood thinner, or you've got something, we can always give you a local anesthetic. So we have probably 6 or 7 different types that, if you're allergic, some have more, some have less, some have more epinephrine, some have 0. So we got all kinds.
Yeah. So I think what's really important to remember is, no matter how long you've been coming to the dentist, and we've got your file, it's always good to make sure it's been updated every couple of months. If anything's changed, make sure that you've let the office know so they can update things, so we're aware in the backside before we do anything what's going on with you and how things are affected. Because we talked about those big 5 and the reasons why they're, but even local, like you said earlier, the local anesthetics can cause reactions with the epinephrine and increasing heart rate, and with things coming down the road like our moderate sedation and things like that, it'll become even more important to have a very detailed history because of drug interactions.
And we're not being nosy, but we need to know if you've had chemical dependency. We need to know it. We need to know. If not, we're going to find out somehow with the internet. When we write a prescription and we don't know it, we'll get called from the pharmacy and say, hey, do you know that he's taken this? Do you know that he's been on that one? We've run what's called a CASPER report. So we're supposed to run that. Every time we write a narcotic, we're supposed to do that. So it's better to just be up front. And we won't say a word. We won't hold it against you, and we won't. No judgment here. We've all had our trouble with stuff. So
right, we treat everybody equally. Our goal is to get you out of pain and fix whatever problems you're coming in for. I hope this helps you to understand why that medical history part is on those forms and why it's so very important, and why even if you've been with us for several years, we may say, you know what, it's been a while since you filled out some paperwork. We need you to fill it out again. I promise we're not just trying to give you some busy work. We really need that information to make sure that we're doing the best that we can treat, like Doc started off with saying, make sure we're doing no harm, and that's the most important. So before we let everybody go, Doc, anything you'd like to tag on with this, with medical histories and why it's so important?
We only hit about 5 of these things, but there's 30 of them on here, and most of them we just draw a line through. We don't specifically need to know unless there's something we're doing, and then we'll ask you. So
right.
Don't worry about it.
And just one more thing I want to touch on. You were talking on about why we ask the chemical dependency and things like that, and we know that it can be a sensitive subject and embarrassing. Also, different STDs can also be a very sensitive subject, okay? And nobody likes to talk about it, but that's a very vital thing for us and for you as a patient. We want to make sure that we keep you safe. We want to make sure we keep the staff safe, and there's different ways we can approach things while we're doing things with that to make sure that we're not making that situation worse for our patient as well.
Yes, generally we won't even know that, but it is on our daggone list, and I'm not sure what's on there, to be honest. I'm just trying to go before we talk. That's the one thing that I'm gonna scratch through that one. I don't want to know that.
It just helps us keep that treatment fully all the way around, and again, we're not trying to be intrusive. It just helps everybody stay safe all the way around. So, all right. Thanks for joining us, and we will see you next time. I think we've got something very special coming up next month that'll be a little bit different than what you've been looking at over the recent months. So
stay tuned.
Stay tuned. We got some exciting things coming up.